My name is Dr. Alan Scott. I did my PhD at the University of Calgary in population and public health, specifically looking at global health issues and working very closely in Tanzania and Ethiopia. I'm also a board member on the Canadian Coalition for Global Health Research, and I'm really passionate about unintended harms and public health interventions. I guess I've been working in Tanzania quite substantially since 2006. And what we've been doing there is working at a really small, really rural, remote hospital that has very limited resources. And one of the first things that the medical officer in charge said to us is, we think that there's a problem with malaria overdiagnosis. All of the slides are coming back from the lab as positive. And this is a low transmission area for malaria. This shouldn't be happening. And why is this happening? So this was one of my first things that, I just started a master's degree, and this was one of my first issues that people had said to me as I'm working in Tanzania. And what we actually found was that it is a problem. So in the data that we found, it was about 70% of patients were being overdiagnosed as having malaria when they actually didn't. So this is a significant issue, and especially as we're starting to see decreases in malaria prevalence due to success of preventative measures such as your insecticide-treated nets, indoor residual spraying, we need to make sure that we're only diagnosing actual cases of malaria as positive and treating with antimalarials, because otherwise you get development of drug resistance, patients are paying for drugs that they actually don't need, and you're going to be missing all of these other causes of fever. So, that question that's really important now that we hear from the district medical officers in Tanzania is, if it's not malaria, what is it? And so this has become the new issue as we've been moving towards the goal of eradicating malaria. Definitely. As I was saying, now that we're seeing less malaria, we need to know, is it a true positive case for malaria? Is it not a true positive case? And importantly, if it's not malaria, what else can it be? Because in a lot of countries that I've worked in, there's a saying, and the saying goes, if it's fever, it's malaria. And it truly is a culturally embedded idea that has come from this safer than sorry mindset. Malaria was really common. Nobody wants to miss a case of malaria. And so if you don't have the diagnostic capacity to say, well, it's not malaria, but I have no idea what else it is, then what do? You're likely going to treat for malaria, and you're going to give a broad spectrum antibiotic or something like that, just to be safe. And this is good practice. But if you can create a diagnostic that moves one step further than the rapid diagnostic tests, which is what you guys are working on, so not only it's not malaria, but also maybe it's pneumonia, maybe it's tuberculosis, maybe it's typhoid, then the clinician is able to say, okay, I'm not going to treat you for malaria, and I'm actually going to be able to treat you for what you're more likely having fever because of. So I think this is really going to move the ability to treat patients appropriately, to make sure that drug resources are used wisely, to save patients money and time from having to go back and forth from the hospitals if they're not getting better. And it also could potentially, improve clinician or the trust that patients have of clinicians, because they'll be able to say, maybe you don't have malaria, now you have this. So I think, there's a lot of application. It's a really exciting field right now. Diagnostics are, one of the key components when you're looking in grand challenges and these things that are actually going to improve health. So I think it's going to be great.